Welcome, everyone. My name is Christopher Hall, and I'm happy to welcome you to Fighting the Syphilis and HIV Epidemics, Voices from the Field, which is being hosted by the National Coalition of STD Directors. Very happy to have you on this exciting call today. I'll just introduce myself by saying I'm an infectious diseases physician and serve as the chair of NCSD's Clinic Plus Clinical Advisory Committee. Having worked over 20 years in public health and community settings in STD medicine and HIV, I have a deep interest in screening and testing strategies for both these infections. And I'm thrilled NCSD is convening this meeting to hear directly from folks in the US about their experiences utilizing new test technology in this space. We also thank ChemBio for their support of this initiative that has led to this webinar. Next slide. Just going over the agenda briefly, I am going to give you a brief overview of the issues surrounding testing for syphilis and HIV and the importance of new test technologies for identifying syphilis and HIV. And then we are going to go to 3 individuals around the country who have actually piloted a new test technology. I will be introducing them and giving you their bios a little bit later, but you can see we have individuals from San Luis Obispo in California, from Oklahoma City, and from Kansas City. So we're very excited to have those speakers on the call today, and I will get back to them in just a few minutes. So next slide. So I don't think it's a mystery to anyone attending this call as to why we believe that syphilis and HIV is a dangerous duo and why we need new test technologies to address the crisis of syphilis infections and certainly the continuation of HIV infections in our country. Syphilis facilitates HIV acquisition an estimated 2 to 4-fold and transmission an estimated 2 to 9-fold. There was an important report in 2004 that was put out by Kate Buschatz and Dr. Jeffrey Klausner. They published this in AIDS, a review of patients from 3 clinics that looked at how syphilis can enhance HIV transmission by increasing viral shedding. Specifically, we know that changes associated with the syphilitic chancre can disrupt epithelium and mucosa to facilitate more efficient HIV transmission. In addition, infection with syphilis has been shown to decrease CD4 counts in HIV-infected patients, and as we just said, increase viral loads that can lead to accelerated transmission. Next slide. So a few statistics. In 2019, approximately 15% of persons living with HIV were unaware of their infection. And back in 2017, it was estimated that persons who were unaware of their HIV status were responsible for 40% of transmission of HIV. So you can imagine that folks, many of whom do not know about their HIV transmission, who are acquiring syphilis and having syphilis, and given this interplay between the 2 infections, creates a very dangerous milieu. And I'm going to show you a graphic that makes that point a little bit clearer a couple slides later. But separately from that, a few years prior, an estimated 38.5% of men infected with syphilis were co-infected with HIV, with nearly half of those cases disproportionately affecting MSM. So in that roughly 40%, the fact that syphilis was occurring meant that the co-infection with HIV led to increasing opportunities for HIV to be transmitted. Moreover, the last point is the increases in syphilis have been fairly consistent. During the 2018 and 2019 period, there was a 30% increase. And if you look at the broader period between 2015 and 2019, almost a 200% increase as depicted in that graph. So the problem is not getting better. The threat is out there, and new testing technologies are extremely important in trying to get a handle on this. Next slide. Now, Also important is the mounting crisis of congenital syphilis. So the national rate of about 50 cases per 100,000 live births in 2019 represents almost a 300% increase in that prior period I just talked about. So nearly 70% of infants with congenital syphilis are born to mothers who receive prenatal care, detection and treatment. Detection and treatment of maternal syphilis, often occurs too late to treat the fetus and to prevent congenital syphilis. So recent data suggests that while screening rates for syphilis infection are generally high, the proportion of women screened earlier in pregnancy remains low. And this can vary by state because, as we know, requirements, or both recommendations and requirements for testing for syphilis, vary by state. And I'm going to talk about that one more time in just a moment. But untreated syphilis in pregnant women results in infant death in up to 40% of cases. I mean, that's a very high mortality rate. So a testing strategy that relies on the use of a treponemal test first may actually be quite important in this population. And we'll get back to that, of course, in just a moment. So a few reports really emphasize the importance of the interplay between syphilis and HIV. And this one from the 2018 surveillance report of CDC, which is referenced there, was the CDC's State of the Union. Ann Kimball wrote an extraordinary report, and I encourage everyone to read that. If you can see it in the very fine print at the right of the slide. Next slide. Next slide, please. Okay. Another very important report was the National Academy of Sciences, Engineering, and Medicine report this year. We call it the NASEM report. It came out this year. The reason I wanted to excerpt part of that report by in there, and you can see a little graphic from Mike Cohen and Chris Pilcher. Even though it's a little old, it's in cartoon form, really illustrates the fact that you can see these bumps of viral load in patients who are otherwise undetectable when they have an STI, such as syphilis in particular. So that's an important concept for us all to keep in mind, is that even if you're undetectable with HIV, when you have intercurrent syphilis, your viral load can increase, and that can lead to transmission events. Next slide, please. All right, and everyone on this call probably has heard of or actively participates in EHE, ending the HIV epidemic. Looking at our goals here, we can't achieve these unless we have optimal and innovative testing strategies to identify folks with syphilis and HIV. And so that is a very important reason we're having this call today. Next slide. Okay. Quickly, I'll just point out that there are two approaches for testing for syphilis, which I think people know. In that little chart on the right, you can see on the left side of that is a traditional algorithm that starts with an RPR, VDRL, goes on to confirm that test with the TPPA or FDA, TBS, ABS, or EIA in some cases. And then the reverse sequence, or the reverse algorithm, you can see on the right, which starts with an EIA. The reverse algorithm has been pursued because it can be automated in many labs. It turns out that the test technology we're going to be talking about today actually employs an EIA first strategy. So that's just an important thing to keep in mind. If you're testing in a population with a lot of syphilis, it may be preferable to go with an RPR initial strategy. If you're testing with the reverse sequence, I'm sorry, if you're testing in populations where there isn't a profoundly high endemic rate of syphilis, then EIA first is certainly okay. But there are lots of issues to discuss there, and it may come up in the Q&A if you have some of those. Next slide, please. All right, so let's talk about the assay that we wanted to introduce today and the experience from the field in deploying it, which we're lucky to have on this call. So the DPP HIV syphilis rapid test was FDA approved last year in October 2020 and launched this year. Currently, it's moderate complexity, but there is a pending CLIA waiver application. And we have no idea when that will come through, but we think it is likely that this will be a CLIA waive test. This would be the first and only FDA approved combo HIV syphilis rapid test in the US. And you can see the depiction of it there. You can see the card on the left with the two buffer areas. And you can see a device, which is the blue box in the middle, I'll talk about in just one sec, which basically standardizes the reading of the result. And we know when we have some of these point of care assays, a lot of training goes into how you read a test. So to have a device that will actually sort of cut down on the subjective reading of the test, I think is potentially very important. Next slide, please. Okay, everyone wants to know the important question of, well, how good is this test? So you can see some performance data there for both the HIV analyte in the middle column of the box on the lower left, and then the treponema pallidum or syphilis analyte. You can see sensitivity and specificity is very high for HIV and quite high for syphilis. And this requires only 10 microliters of either finger stick, whole blood, venous whole blood, or plasma. And the result is provided in 15 minutes, which I'll show you in a second. I won't go into the interpretation of the results, but you can just see a table there which shows you the display of the test result and the associated interpretation in the little blue box. Next slide, please. And that's the little blue box, the DPP micro reader we've talked about a bit, but for purposes of time, I'll just go on to the next slide. And the next slide shows you the steps involved in this 15-minute assay. The finger stick blood collection and the use of the buffer, putting the 2 drops on the test cassette. You want that to incubate for 5 minutes, and then adding additional buffer, 4 drops in the other well, and incubating the sample in the cassette for 10 minutes, so a total of 15 minutes. Then the reader that we were talking about is used to essentially read the result of the test. And so that's the basics of it. If there are additional questions on as to how it works, we can definitely get to that in the Q&A. So next slide. So just a few use cases. Here at NCSD, we solicited interest in a pilot program to basically use this new assay around the country. And these are some of the use cases that were identified for us among people who might have used the test. So you can see any number of ways of using the test, testing women prenatally. There was a desire to use the test for the homeless, marginally housed population, desire to streamline workflow in a program or clinic setting. So a number of possible ways of using the test. And I am going to now go to the next slide to say that we are delighted to have some individuals on the call today who are going to go beyond just talking about the possible use cases, and in fact are going to tell us about the ways that the test was used in their centers in actual pilot demonstrations of the test. So because I gave you that long break earlier, I'm not going to go into a whole lot of detail on the bios. I'm going to introduce these folks and ask that they briefly introduce themselves at the beginning of their slide sets. But first of all, I'm going to introduce Kayla Wilburn, who's the clinical director of the Center for Health and Prevention at San Luis Obispo. And Kayla, if you want to say a little bit more about what you do there and then go through your slides, I'll let you take it from me now.
Thank you. Hello, everyone all over the country. Thanks for chiming in the chat and sharing where you're joining from today. I'm Kayla Wilburn. I am with the Center for Health and Prevention Clinics, a program of community action partnership in San Luis Obispo County, California. We're located midway between Los Angeles and San Francisco on the Central Coast. And we're mostly rural and have a big divide in our county in a physical barrier called the grade. It separates our county into north and central and south counties. And As we're seeing across the country, we continue to see an increase in STIs and HIV. And so I've been part of the statewide In the Epidemics coalition for several years now. And that was one of the reasons that I was so excited to have an opportunity to participate in the pilot program. And so I'm glad to also share with all of you a little bit about our experience. Next slide, please. So currently, we're still doing this, and I'll get to that in a bit. So our workflow consisted of offering the HIV and syphilis testing separately. So our basic test offering is the big three: chlamydia, gonorrhea, and HIV. And then syphilis when appropriate or when the patient is interested. And we have a whole algorithm that we follow, as many of you do, to identify syphilis testing appropriate patient. So the tests that we were using, both rapid tests, the syphilis test required the use of a pipette, and that would often result in us having to do 2 finger sticks instead of just one. Patients are already not super excited to be in the clinic anyway, getting testing. And so it didn't help with anxiety. And it also slowed down our workflow a bit. We operate with 1 medical provider at each site and 4 to 5 patient services assistants, which in our clinics are highly skilled medical assistants that do all of the health education and counseling around STIs, HIV, and contraception. So we were hoping to improve our workflow, make the process for our patient services assistants smoother and streamlined. We're hoping that patients would be happier only being stuck once and not spending a lot of time having the patient services assistant milking the finger, trying to get enough blood to run both the HIV and syphilis rapid tests. And we were hoping that there'd be more of an uptake with the combination test because we do offer opt-out testing, and I'll share a little more with you about that in just a moment. Next slide, please. So in preparation, the ChemBio folks came out and trained all of my staff at both sites, and staff had a lot of fun. They said it felt a little bit like chemistry class, and they picked it up really quickly, had no real concerns about running it, and we're really excited to offer it in the clinic and see how that went. We publicized the availability of testing on all of our social media. We also do some outreach on campus at the local high schools. We have 2 community colleges nearby and the university just right up the street, Cal Poly San Luis Obispo. And so we used all of our contacts that we work with community partners. We reached out to the Gay and Lesbian Alliance and the Hep C Project, let everybody know what we were working on. And the patient services assistants started crafting language around the opt-out testing. We worked on what our workflow would look like because the test does take a little bit longer and is multi-step. And we needed to set up our little tiny laboratory in the clinic to be able to accommodate all of the test materials and timer, and just did a little reworking of the space. We began our testing on April 19th and ran the pilot for 2 weeks and barely made it because we ran out of tests, which was a really exciting result. I didn't really have to wait to talk about outcome data and debriefing with the clinic staff because they were constantly coming to me and talking about how much they liked using the test. Next slide. So as you can see from the numbers, we run, you know, a decent number of HIV and syphilis tests, not a ton. We're a small facility. Again, we're just 5 blocks from Cal Poly University, and I think 6 from the high school. We see a lot of young people. We only see folks with Medicaid insurance or no insurance. We don't accept private insurances. So we're really serving low income, uninsured, vulnerable folks, including a lot of young people, which in our area and probably in some of yours, younger folks are the ones testing positive for HIV and syphilis. And so we're trying to get a handle on that. And we feel that this test is going to help us do that. The patient service assistants came up with a couple of different scripts, and they picked their favorite, and I'll read it to you now. So the patient would come in and we would let them know kind of our menu of services, and the patient services assistant would say, common STIs are chlamydia, gonorrhea, HIV, and syphilis. So those are the tests we're going to run for you today. For chlamydia and gonorrhea, you'll give us a urine sample that we'll send out to a lab. For HIV and syphilis, we're using a new cutting-edge rapid test that only takes a drop of blood, and you'll have your results in 20 minutes. Do you have any questions? So the language evolved a little bit, you know, depending on the patient. The patient service assistants have conversations rather than just presenting information, but that was the basic message that was given to the patients. We ran out of the chemo bio test in 10 days. We had no one who was offered the test decline it, and patients showed a lot of enthusiasm about being able to get both tests results while they were here, and really just a finger stick and a loop of blood. Next slide, please. So results, we had 1 positive HIV, and a separate patient tested positive for syphilis. Both of those were confirmed at the lab. And so our 2 positives we know were caught early, and we were able to treat the patient who tested positive for syphilis based on our clinician's algorithm. And we were able to refer the HIV positive patient for immediate care. So that was really exciting. We didn't expect to really have any positives in a 2-week period. The things that the patient services assistants or medical assistants really liked was they only had to do 1 finger stick, because they were able to collect, you know, just a loop of blood and get enough to run the test. They were able to talk with the patient because it was just 1 finger stick and 1 loop. They could talk to the patient and help them feel comfortable because it took less time. It turned out we needed less space in the lab. We had more time with the patient, and the patient services assistants couldn't say enough about using the test and feeling really comfortable with it, and the improvement to workflow. Next slide, please. So as a member of in the epidemic statewide work group, again, we're really looking to use this as a tool to help us locally and to share out as part of that work group with our colleagues statewide what we've learned, how simple the test is, and how we see it as something that can be used in a variety of settings. We used to call it the big three, chlamydia, gonorrhea, and HIV, and now we can add syphilis and not really change our education and workflow. We just add in more information about syphilis and co-infection concerns and rates. We have an algorithm for our testing, and I'm happy to share that with you. I also share out the script that the patient services assistants created during our preparation. Next slide. So next, the whole team is working on creating educational videos that we'll share out on social media, and I'm happy to share with anyone who is interested. We are in the process of preparing for the fall to be either on campus or hold special testing days in our clinics to welcome students back and get testing out of the way right at the beginning of the school year. We are promoting currently on all of our social media accounts, as well as dating sites, which was new for us starting last fall. And we've had a lot of really good feedback. What we had heard in the clinics is patients coming in saying, you know, I know I'm not supposed to because COVID, but I'm hooking up on Grindr, and I need testing, or I need condoms, or whatever supplies. And so we decided to start advertising to be able to reach out to those potential patients and current patients and say, no judgment, just come get tested and get what you need to be safe. Also, we are just awaiting our final confirmation that we have been approved as a PrEP enrollment site, and that will allow us to enroll individuals into a program that will pay for their PrEP services. We are already a PrEP provider site, but we'd like to do it all in one visit, enroll them, provide them services, get their testing done, and they can go home with their medications. Next slide. So this is half of my team. They're amazing. We couldn't have done this without them. And this is my contact information. So please feel free to contact me if you'd like. Oh, I forgot one thing. We only have a CLIA waiver, so we were thinking that we'd wait for the test to become CLIA waived. We're not waiting, the staff won't let me. So I'm in the process of applying to get our approval for running moderately complex tests. So I'll end there, and I'm gonna pass it on and introduce Russell in Oklahoma City.
Thank you, Kayla. My name is Russell Rooms, and I am the CEO and lead nurse practitioner for Diversity Family Health, based out of Oklahoma, but have franchises now that are available nationwide. But we're a private practice, family practice agency that focuses on the LGBTQ community and providing primary care in a location that is free of discrimination and bias. And so based on that, we do a lot of HIV care, as well as PrEP and PEP services. So we were really excited to be part of this this testing, or the new test that ChemBio has for HIV and syphilis.
Russell, you went on mute.
Next slide, please. I'm sorry. That's why it's not changing. There we go. So we currently use the ChemBio sure checks for HIV 1 and 2, and then we have to send out our syphilis after a venous blood draw. And so it takes us about 48 hours for those to come back. And as the clinicians will understand that, we can have people out there that are exposing more people as that time rolls on. And we've seen the same true with, gonorrhea and chlamydia, that the longer it takes, the more exposures can be out there when people are asymptomatic. So in our clinic, most specifically here in Oklahoma City, we see about 16 patients per day for PrEP services. Usually we have 2 providers, so it's about really twice that we see every day. Most days of the week we have 2 providers. And we perform about 350 HIV tests per month. And those are specifically those sure checks. So those patients that are HIV, that we don't know their HIV status, that they're PrEP patients or coming in for STD testing. So it doesn't include our other patients that could also have syphilis that are currently under HIV treatment. Next slide, please. So what we wanted to do, because as part of our End HIV Oklahoma project that we are part of here at Diversity Family Health, we do what we call PrEP fests where we've partnered with different universities, either with their LGBTQ centers or their on-site clinics, to do quarterly HIV testing and PrEP fests. So that way, most of them are residential colleges so that way that patient does not have to come to a clinic, but instead we kind of go to them to make sure that they get their PrEP services. So we were really excited to be able to add not only to that HIV and PrEP, but also be testing for syphilis on site. So we wanted to see how easy would it be for us to use this test in that kind of festival setting or a mass testing type of setting, and see how it would work kind of in rapid succession when you have multiple people coming per hour and the test taking 15 minutes. So that's what we were focusing on during our little pilot. Next slide, please. So our local college, like I said, was offering free HIV and syphilis testing and PrEP. And so basically there were 20 students that had pre-scheduled to come to the PrEP Fest. However, it was open to walk-in availability as well. And so of those 20 that were scheduled, 16 of them showed up, and we didn't have any walk-ins to the clinic this day, or to the LGBTQ center, actually, where we were doing this testing and PrEP Fest. We wanted to use this event just because we knew it would be really kind of low volume, not the mass testing that we would have at a Pride Fest or something like that. So we wanted to kind of test it out at one of our more low volume just to see how things work and the best way to situate things. Anyway, out of those 16 students that showed up, 3 had a previous history of syphilis. So we excluded those patients and didn't use the ChemBio test just because we anticipated there would be reactivity and we wouldn't be able to do anything with that. So for any of those patients, we did a lab draw and sent it off for an RPR. 13 students were tested using the DPP HIV syphilis test, and those students had varying degrees of sexual activity in the recent and distant past. And all of those students, luckily, were non-reactive for both HIV and syphilis. And so the thing to keep in mind, too, is that, we do a number of these, and we have had positive HIV and syphilis. So even though we expect that, 13 would be non-reactive, for both HIV and syphilis, we've had even smaller events where we've had people that are positive, and we've changed those into rapid start situations as opposed to PrEP situations. Anyhow, 4 of the 13 students, they were at risk for HIV, and so they chose to start or continue their PrEP. And for those 4 students, we did some confirmatory laboratory testing for HIV and RPR, which were consistent with the ones that we did with the rapid ChemBio test. And those were also non-reactive. Next slide, please. So in conclusion for us, what we found was that the tests were really easy to use, and they were very straightforward. We loved the ability to have the little blue box that gave us the results as Dr. Hall said, taking the subjectivity out of, I think I see a line, do you see a line, out of the equation is really great. So they were really easy to use, had that test that was either non-reactive or reactive. When we had multiple students kind of in quick succession, we had created some labels on Word that gave us, the patient's initials, the well time 1, the well time 2, the read time and results, and had a digital clock. So that way we would have a consistent time for that, as opposed to the different clinicians looking at their watch. So those were things that we kind of anticipated, and we put those in place, even though, in the 4-hour time period of this Prep Fest, we didn't have a real rapid succession, but there were several of them that were backed up. And that was one of the goals we had of the study, is seeing, if it's in rapid succession, how would it work? And so the test could then be read in quick succession. So, patients would be waiting for their results, and then we'd be able to pull them up and see them, minutes apart, as opposed to having to wait a whole 15 minutes for a backlog, if we were doing one at a time. One thing we did, because we had different clinicians doing the test, and all of them had training on the test prior to performing it. But at larger events, we're planning on having either a clinician, whether it's a lab tech or an MA or one of the clinicians that is really just concentrating on doing the test, as opposed to scoot over a little bit because I need to get some level 1s, and now can I have the reader and that kind of thing. So we're going to have one person that's their responsibility, is to do that when we have larger events that we will have patients in large succession, to make sure we keep that straight. So again, we're excited to start using that. We have just bumped up to a moderate lab because we're starting to include some instrumentation that allow us to give GC and chlamydia results back from swabs as well as urine in 30 minutes. And so we're excited to start being able to use it in the clinic, and as soon as it's CLIA-waived, be able to use it at more of these festivals and things like that we do in the community. Thank you all for having me here to tell a little bit of the story of what we were able to accomplish with the new ChemBio test. And again, we're excited about it. And I'm going to pass it on to Johnny Gonzalez for his section.
Hi, hello. Thank you, Russell. My name is Johnny Gonzalez. I work in KC Care Health Center here in Kansas City, Missouri. We are the city of barbecue, so I know I'm not gonna fight with anybody, but I know we love barbecue here. So we are a small clinic in Kansas City. I know that everybody think that Kansas City is part of Kansas, but we actually are in Kansas City, Missouri. And then we decided to, when we applied for the pilot program, we wanted to start helping our community to be able to get tested for syphilis. Inside our KC Care Health Center, we have my clinic that I am the coordinator. We call it CATS for short, but it's Counseling and Testing Services. Somebody came with the name CAT, so we stick to it and we like it. And we were offering syphilis testing, but the number were very low. One, it used to be very uncomfortable. People don't like needles. Everybody knows that. And also, since COVID started happening, the state lab was taking longer to provide the result for RPR. So when I heard about this program, I jumped in. I got the green light from the chief medical staff so I can be part of the pilot program. So that's why we ended up participating, and we're very grateful that we were selected. So next slide, please. So our objectives in the pilot was, like I mentioned before, it was to increase syphilis testing and in our walk-in clinic using the DPP test. It's less invasive, and we were hoping to provide fast result and reduce wait time, especially here in our lab because we're a small center. Our lab can get so crowded that people usually walked out, And then when I go, it's like, we had 10 people for RPR. Oh, no, they all left. So it was really causing a backlog. So that was the objective of the pilot program. Uh, Next slide, please. So the design of the study was to offer the Cambio DPP to all patients that come to our walk-in clinic with no history of syphilis in the past, and increase the number of patients testing for syphilis. To a caveat to that, since I was the only one trained from my team, I just explained my team, let people know that we're gonna be doing this new test. So I ended up getting so many calls that I had to, like one time I had to say, give me a break because everybody, I know there's a saying that say, be careful what you wish for. Everybody said yes when we started implementing it. So since I was the only one, I was running like back and forth. So I had to take breaks from time to time because everybody said yes to the rapid test, because people felt comfortable since we don't have to do a vein puncture blood draw, and also they will can get the result right away. So that was really good. And I immediately after I saw how people were saying yes to that, I trained in three more people so they can help me. The only problem is we only have one reader, so we were fighting for it. But that's we'll get to that part later. Next slide, please. So, and in conclusion, patients felt more comfortable and willing to test for syphilis because when we used to explain the new test that we were going to use, people felt really comfortable. So we ended up getting the triple number of tests that we do per month. People that I immediately said, yes, I would like to get that test, get the test with you. Uh, so we tested more than 24, but during the process, this is what I have when we provide the result. We retest 24, and out of those 24, we found 3 reactive for HIV and 3 reactive for syphilis. It's good to know, as Christopher were mentioned at the beginning, people living with HIV sometimes could be exposed to syphilis and they didn't know. So two of those cases, people were really surprised that they were coexistent with HIV when we used the test and then came back reactive. All those tests, we did a confirmatory just to follow protocol in our clinic and they all come back, uh, they all confirm the result that the DPP test has. So only one was reactive for syphilis by itself, but that was the finding that we have during the pilot program. Next slide, please. So the conclusion is it was easy process. The staff that I trained, the feedback that they gave me is like, it was so easy to use, like there was no problem. So I love that feedback because sometimes training staff, that's uh, my main work every day is trying to train staff. It makes it easy for me to train people when they felt like they was easy, comfortable for them to also run the test. Since we usually see a high population of people that are homeless or people that are injecting substance, we also have a problem that we have a lot of people with a scar in their veins, they're dehydrated. So that test also help us that with a finger prick, we were able to get the blood easily with a 10 micromilliliter and then be able to test them. Also, we reduced the waiting time in our lab and also at the state lab level because we didn't have to send as many RPR that we do monthly, even though it's not a law, but only we send the ones that came back preliminary reacted for confirmatory. Most patients felt comfortable with the test because it was minimally invasive and you get the result right there. Other patients didn't qualify because of the history of syphilis in the past and also since we are a clinic that has other tests that we can detect recent exposure, like for example, to detect antigen. So then we decided not to use the DPP on those cases. So that was the conclusion that we found by using the DPP test. And we did also outreach event where we were able to use the test and outreach event on the street, um, following CDC guidelines, but people need that human interaction. So we started doing outreach event on the street, and they will also be able to easily be used in outreach event, and people decided to get tested because we have the HIV and syphilis test right there to be able to provide it to them. So I am very excited for the test. I think I'm gonna be jumping in as soon as it's available, because I feel like it's gonna help us to continue providing um, testing in the community that is totally needed, and also it's gonna be able to make people less anxious to come and get tested when syphilis now is gonna through be able to be done through a finger prick. So that was our finding. And um, yeah, I just mentioned that, but thank you. And thank you for listening to me.